Yes, we are live now.
Yes, you're right. So, Priya, please.
Yeah. So a very good evening to all of you who all are present here. Warm greetings from all of us. And on behalf of Indian Society of Perinatology and Reproductive Biology, we cordially invite you for the Seed to Bloom series, that is episode 8, by the Fertility Enhancement Committee of National ISOPAB on PCOS across life cycle. This is in association with the Delhi, Jamshedpur, Agra, Telangana city chapters of ISOPAB. So, a warm welcome to everyone. And let me have the CV of, let me start with the Ganesh Vandana. Yeah. Before we start any auspicious event, we start with the prayers to the Almighty.
वीडियो नहीं है, आवाज नहीं है, ऑडियो नहीं है.
She's trying, I think.
आज इसको कुछ टेक्निकल ग्लिच है.
Audio is not there, but
Today audio is not there. No issues. So it is silent inauguration by all the dignitaries.
yes. So thank you, Sahiti. We can have the CV of Dr. Lakshmi Shekhande, madam.
Just flash it.
So this program actually is the brainchild of Madam Dr. Lakshmi Shekhande, who is the chairperson of this Fertility Enhancement Committee of this National ISOPAB, and she is also the convener of this program. Madam is the medical director of Shekhande Fertility
Supriya,
Clinic, Nagpur, and Madam
go to
has
the previous slide because I would just like to brief the brief outline of the program. Just go to the previous slide, Saiti. So, very good evening, one and all, and I am very happy to welcome you all for this episode 8 of our Seed to Bloom series. And today, our theme is PCOS across the life cycle. And I'm so happy that today our international faculty is a very renowned person, Dr. Yusuf Latif Khan, who has joined in from Pakistan. Welcome, Yusuf. And I'm so happy that this is the first webinar under the presidentship of Dr. Narayan Jana. So thank you so much for allowing us to continue our this series in your tenure. And welcome Pragya, she is the Secretary General of ISOPAB. Bhaskar Pal, our chief guest, and Supriya. Without Supriya, this series just cannot go through. She is the co-convener and she's doing all the coordination work. Friends, today we have thought of 3 talks. That is adolescent PCOS, which is very, very important. It will be delivered by Supriya and the session will be chaired by Ruchika and Pratibha. Then second talk, that is fertility challenges in PCOS, will be given by our international faculty, Dr. Yusuf Latif, and it will be chaired by Dr. Mala and Dr. Jyotsna. And third will be metabolic disorders in PCOS, which we usually don't talk. That is why we have kept that also in this webinar. And that session will be chaired by Dr. Chandra and Dr. Sarita. So with this short brief about the program, I once again welcome you all and welcome to all the dear delegates who have logged in. I know I can't see you all, but happy to have you all. And without wasting much time, now I am handing over to Supriya to start with our program.
yes. Thank you, madam. Thank you for briefing everyone about the program, about the whole series, what we are doing. So we are have As you said, we are really happy to have as chief guest Dr. Narayan Jana, sir. So can I have the CV?
Yes.
Saiti? Sir is at present the president of ISOPAB National 24-25. He is the professor and a professor at the Postgraduate Institute of Medical Education and Research Center, that is at Kolkata, and he has special awards and achievements like Korean Award, ISUOG Awards. He has Dawn Prize and medals. Former Vice President Chairman E-Zone of the ISOPAB. He'd been also be the member of Task Force and Project Advisory Group ICMR Delhi, Expert Group Government of India, peer reviewer of several national and international journals like NEJM and BJOG, IGO, IGMR, and so many research and publications. He had got many, more than 60, and several chapters in the textbook. Special contributions is tuberculosis in pregnancy, low dose magnesium sulfate in eclampsia. Sir is a teacher of teachers, and really the students, the new ones, they love to have this CTG sessions and everything. Sir had taken so many sessions. Sir, over to you for your words of wisdom, sir. Bless this webinar.
Thank you. Thank you very much. Namaskar and good evening to everybody. It's a great pleasure being with you this afternoon. On behalf of Indian Society of Perinatology and Reproductive Biology, I welcome you all with open heart to be with us this evening. It is a great brainchild of Dr. Lakshmi Srikhandi, who started a unique program that is Seeds to Bloom, very unique in its title. And this is an unique aspect because PCOS across the life cycle is an epidemic at the current state. I'll not go to that details of this, but what I appreciate very highly about the speakers who will contribute their knowledge, experience, and expertise to us. When you give someone something, a material, it will be lost. But if you give something, a knowledge to someone, the knowledge spreads. In Indian society is primarily a society of knowledge-based society. And the very ethos is Daneno Biddhi Mayati, Khayang Mayati Sanchaya. More you donate knowledge, it increases. It never decreases. So I am very proud to welcome three of our speakers. Dr. Supriya Jaiswal, our very Supriya, which is very much close to our all activities. And very warm welcome to Professor Yusuf Latif Khan from Pakistan and a representative of SAFOC. We have heard him earlier also. And Lakshmi. Lakshmi has started the ball rolling in my presidency. Thank you, Lakshmi, to start this academic program. And thank you for sharing your knowledge, expertise, experience to all of us. Let this event become a grand event for all of us. And I wish you all a grand success in this program. Only one request, please enhance and increase the activity of ISOPAB, increase the membership. Yes. Membership is our strength. More we are, more vocal we would be to change the lot of important activities. Thank you very much once again. Very warm welcome from core of my heart. Heartfelt thanks to you, all of you, once again.
Thank you, sir.
Thank you, sir. Thank you for your words of wisdom, sir. And once again, congratulations for taking over as the president of National ISOPAB. Thank you, sir. So, Dr. Pragya, I think she couldn't join, but just to formally introduce, she is the Secretary General of National ISOPAB. She is the consultant infertility specialist at New Life Test Tube Baby Center and MGM Hospital at Patna. She's been the Secretary General now till 2024, and she's also the chairperson genetic and fetal medicine. She was in Fox. For Foxy, it was 1618, and she's also the founder, Secretary Bihar chapter of ISAR, and many more accolades to her credit, so many awards to her credit, and a vibrant personality. She'll be joining shortly, so I welcome on in absentia. Now, Dr. Bhaskar Pal sir, who's the guest of honor of this program. Sir needs no introduction. Everybody knows him, and he is a senior consultant gynecologist at Apollo Multi-Speciality Hospital, Kolkata. He is the chair of AICC-RCOG, immediate past president IAGE. He had been the FOXY representative to CEPHOG in 21-23, where he had lots and lots of activities along with FOXY and CEPHOG. Then he has also been the chair, organizing committee AICOG 2023, Kolkata. That was a wonderful AICOG. Immediate past president of Bengal Obstetrics and Gynecological Society, vice president FOXY. 2017, clinical examiner of MRCOG Part 3, and he has authored more than 35 chapters and book chapters. So over to you, sir. Thank you for accepting to be the guest of honor.
Thank you, Supriya. Thank you very much. And at the outset, I take this opportunity to thank Professor Narayan Jana, President of ISOPAB. And I think this is the first webinar under his watch. And also to my dear friend, Dr. Pragya Mishra, for inviting me to be the guest of honor. Special thanks to Dr. Lakshmi Srikhande, the convener of this series, and Dr. Supriya Jaiswal, the co-convener. This has been a very, very popular series, and on a very, I would rather not use the word interesting. Polycystic ovarian syndrome, the more we talk about it, the less clarity we have. Every day the concepts are changing, and our understanding has increased greatly. So it's not only a problem with adolescent PCOS, yes, which we see in abundance, and which Dr. Supriya Jaiswal will speak about, but also the bigger challenge in terms of NCDs is the metabolic disorders, which Dr. Lakshmi herself will speak on. Dr. Yusuf speaking with fertility challenges, authority on fertility enhancing surgeries. It's a pleasure to have Dr. Ruchika from now, Dr. Pratibha Pasari from Assam, Dr. Mala Srivastava from Delhi, Dr. Josna from Telangana, Dr. Chandra from
I think he's traveling.
Yeah.
Bhaskar, are you with us?
He's there. That's free.
And all of us really need to look into that. Thank you very much.
Thank you, Bhaskar, and wish you all the very best for your elections and all your future endeavors. Thank you for being with us today.
Thank you, Bhaskar sir, for being so busy. In spite of that, you joined the webinar, and all the best wishes for his presidential elections, isn't it, madam? Thank you, sir. And now we move on ahead to the first scientific session of this webinar. So to chair the session, we have madam
Ruchika. So now we are starting with our scientific session. So first we are having a talk on adolescent PCOS, which will be delivered by Dr. Supriya Jaiswal. And to chair this session, we have Dr. Ruchika Garg. She is Professor, Department of OBGY at Asad Medical College, Agra. She is currently the editor-in-chief of our CEPHOG journal. She is also associate editor of our Journal of Midlife Health, and she was president of Indian Menopause Society of Agra. She has received many awards, many prestigious awards, and just to mention one, that is the Corion Award in the senior category and also in the junior category. She has got many publications to her credit. So she will be chairing this session along with Dr. Pratibha Pasari. Dr. Pratibha, she is an IVF specialist from Guwahati. She is currently the secretary of ISOPAB Assam chapter, also the joint secretary of Guwahati OBGY Society, and she has been faculty at various national and international forums. So now hand over to the chairpersons to start with our first session.
Thank you, Lakshmi ma'am, for the introduction. And it's a very big opportunity to introduce Dr. Supriya Jaiswal ma'am. So I would like Supriya Jaiswal madam is chairperson of Adolescent Health Committee of FOXY. She is very dynamic. She is also vice president of Patna Obs Gynae Society. and she has taken HPV East Zone project to her credit, and she is joint secretary of so many organizations, including SOVC, Agoi Bihar, an executive member of National ISOPAV, ISAR Bihar, IAG Bihar. So in every organization, she is so much active, and she has so many awards to her credit, including the MP John Award and Dr. Murthy Award for her best paper. She's she's holding so many other posts like Joint Secretary, Clinical Secretary of Patna Obs-Gynae Society, and she has also been organizing so many conferences, and she was the organizing secretary of BoxCon in 2022, and she
Thank
has so
you.
many publications and chapters and Foxy focuses to her credit.
Thank you.
So she will be speaking on adolescent PCOS. So over to Dr. Supriya, madam.
Thank you, Dr. Ruchika, for that kind and generous introduction. So, can I share my screen now? Is it visible? Yeah. Can you see?
Yes,
ma'am,
ma'am, it is visible.
Okay. So I'll be talking at the outset. I really thank Dr. Lakshmi ma'am for giving me this opportunity to talk on this subject. Although we have just 15 to 16, 17 minutes, but I'll try to be very as short and brief. So adolescent PCOS. As you know, I am chairing even in the National Forum Adolescent Health Committee chairperson of FOXY till 25 December. So I have been working lots on these adolescent children in various aspects. So an adolescent PCOS is one of the most burning issues, and everybody comes across this. It is the most common heterogeneous female endocrine disorder. Basically, it's a metabolic disease with underlying ovarian defect, insulin resistance, obesity, infertility, cardiovascular problems, and psychological issues and comorbidities. It's a polygenic, polyfactorial systemic inflammatory autoimmune disease with dysregulated steroid state manifesting largely due to the lifestyle errors. As we all know that adolescence is the period between 10 to 19 years of age that includes significant and critical changes in growth and development and puberty. That is according to WHO. Most common endocrine condition affecting between 8 to 13% of women of reproductive age and 6 to 18% of adolescent girls. So this is the Indian scenario. It is reported as low as 6% to as high as 36%. So the risk factors everybody knows, many risk factors are there related to PCOS. That fetal factors is macrosomia and low birth weight in girls born to mothers with excessive body weight. Adolescent factor, then premature puberty, metabolic syndrome, and obesity. Hormonal imbalance coupled with a genetic predisposition forms the foundation for the onset of PCOS. Subsequent insulin resistance and weight gain appear to contribute to the metabolic dysfunction, driving the syndrome and its complications more and more. So the diagnosis during adolescence is both controversial and challenging due to the overlap of normal pubertal psychological changes, physiological changes with adult PCOS diagnostic criteria. So challenges include risk of underdiagnosis, delayed or poor diagnosis, and sometimes overdiagnosis. So what happens? Only adolescent studies are limited and suboptimal in quality. Adult studies that include adolescents do not specify the number of adolescents or time post-menarche, which is critical information to determine the evolution of normal pubertal physiological changes. So the need for high quality evidence-based guidelines is there. So PCOS is a metabolic disease, as we said, with future consequences like diabetes mellitus, cardiovascular morbidities, and subfertility. This should be treated very early. So early diagnosis, this is very important. This will help them improve their lifestyle and prevent the consequences. Pills given for menstrual irregularities cure other subtle endocrinopathies and at the same time take care of contraception needs. There are many disadvantages like psychosocial issues, labeling a girl as PCOS. These days, when these girls come to the clinics, you will see they first of all they Google and see, and they will only tell you, "Okay, I've got PCOS," and that looking at their all features, they even go to that it will result in carcinoma. So they are very upset about this. So these are the disadvantages. So if early diagnosis and underdiagnosed and at this tender age makes her emotionally labil. She thinks she's sick or something. So overdiagnosis due to overlap mentioned earlier and misdiagnosis. These things should not, we should take care of that. So what do the guidelines say? For adolescents who have features of PCOS but do not meet diagnostic criteria, an increased risk could be considered and reassessment advised at or before full reproductive maturity, 8 years post-menarche. This includes those with PCOS features before combined oral contraceptive pills commencement, those with persistent features, and those with significant weight gain in adolescents. So this is a purely clinical diagnosis. So differential diagnosis also are there like pregnancy, hypothyroidism. So they miss their periods. So these are the other clinical differential diagnostic factors. Then what does the Rotterdam criteria in 2003 say? For girls who are at least 2 years post-menarche, hyperandrogenism and irregular menses are the required diagnostic criteria for PCOS in adolescents. If the patient does not fulfill these criteria, rather than prematurely labeling them as a diagnosis, she can be considered at risk for PCOS. All adolescents with PCOS should be longitudinally followed. Acne and PCOM may be observed but are not diagnostic criteria. Obesity, insulin resistance, and hyperinsulinemia are common comorbidities. So here we see that there are certain diagnostic criteria, exclusion criteria, clinical features, biochemical traits, and PCOM. NICHD in 1990 requires simultaneous presence of clinical or biochemical hyperandrogenism plus ovulatory dysfunction. As of Rotterdam in 2003 requires the presence of at least two criteria, one clinical or biochemical hyperandrogenism, then ovulatory dysfunction and PCOM. Then AES in 2006, they said that it requires the presence of clinical or biochemical hyperandrogenism and either ovulatory dysfunction or PCOM. So these were the diagnostic criteria. There are several. Likewise, we had exclusion criteria. There are clinical features. In NICHD, it was hirsutism, alopecia, acne. Like in Rotterdam criteria, hirsutism, alopecia, hyperandrogenism, androgenic acne, and here we had hirsutism. So these are the different criteria where we have to base the diagnosis. So diagnostic criteria for Amsterdam criteria was oligo-ovulation or anovulation, clinical or biochemical signs of hyperandrogenism, polycystic ovaries on ultrasound, oligomenorrhea, clinical hyperandrogenism or hyperandrogenemia, then oligomenorrhea, clinical hyper. So these were the Rotterdam and Endocrine Society criteria 2013. Be abnormal uterine bleeding pattern, abnormal for age or gynecological age, persistent symptom for 1 or 2 years, evidence of hyperandrogenism. So these were the criteria to diagnose. So irregular menstrual cycle is what? It is normal in the first year post-menarche as part of the pubertal transition. 1 to less than 3 years post-menarche or less than 21 or more than 45 days. 3 years post-menarche to perimenopause, it is less than 21 days or more than 35 days or less than 8 cycles per year. So the primary amenorrhea by age 15 or more than 3 years post-menarche, when the breast develops. So these are the hyperandrogenism and hyperandrogenemia features. What are the history like PCOS? What do we need to do? We need to see the history. What was the age at menarche, cycle length, and what was the flow? Did she have any sudden weight gain, appearance of severe acne or hirsutism or alopecia? And these were the signs and symptoms like excessive facial hair growth, then acne, they get usually alopecia. These youngsters, they are very, very much worried about this. The physical examination, we see general body habitus, presence of acne, as we said, and male pattern of baldness. Then severity and distribution of hirsutism using Ferryman-Galley score modified. Baldness is assured by Ludwig scoring system, as it's known to everyone. Acne by acne scoring system, size of thyroid gland, presence of virilizing symptoms, and marked hyperandrogenism. So modified Ferryman-Galley scoring system, MFG. Here you can see this criteria level 4 to 6 indicates hirsutism depending on ethnicity, acknowledging that self-treatment is common and can limit clinical assessment. This was the Ludwig score for alopecia. This is the typical type of balding in PCOS. The scoring system depended on severity, comedial lesions, and inflammatory lesions. These are the other scoring systems we had. So not much difference in terms of hormonal levels. Laboratory evaluation, we see testosterone. This is the only test required to diagnose PCOS. Calculated free testosterone, free androgen index, or calculated bioavailable testosterone should be used to assess biochemical hyperandrogenism in the diagnosis of PCOS. High quality assays such as liquid chromatography, mass spectrometry, and extraction should be used for accuracy. These are not very usually done, but since in this presentation we have kept because it was elaborate and for teaching purpose also. So laboratory evaluation of hyperandrogenism. These are the data, androstenedione and dehydroepiandrosterone sulfate, DHES, could be considered if total of free testosterone not elevated. However, these provided limited additional information in the diagnosis of PCOS. Prolactin is another one, that mild elevations in prolactin are common in women with PCOS. Only 3 to 7% of hyperprolactinemic PCOS patients having persistently elevated prolactin levels, and then 17 hydroxyprogesterone helps in diagnosing the source of this one. So all these levels need to be diagnosed if it is established case of PCOS. So test not recommended to diagnose PCOS in adolescent is serum AMH. We need not go into these details for the adolescents. Ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years due to the high incidence of multifollicular ovaries in this life stage. Strong consensus recommended. So we cannot diagnose PCOS on this ultrasound because the physiological immaturity of the hypothalamic pituitary ovarian axis. A population study showed a higher prevalence of polycystic ovarian morphology in very young women without menstrual irregularity and hyperandrogenism. So due to this overlap between follicular numbers per ovary in normal adolescents and in those with other features of PCOS, the adult polycystic ovarian morphology criteria are likely inaccurate for the ultrasound diagnosis of PCOS during adolescence. Additionally, the use of pelvic ultrasound will increase the risk of PCOS overdiagnosis during adolescence, and usually we avoid this. Serum insulin and sex hormone, these are not needed at all. Laboratory evaluation for exclusion, TSH, prolactins, DHES, these are the commonly used ones. Then comes here another practice point from the guideline is that ovarian dysfunction can still occur in adolescents or women with regular menstrual cycles. And if an ovulation is suspected, serum progesterone level can be measured to confirm it. So these are the metabolic screening. Weight, height, and ideally waist circumference should be measured and BMI calculated with the following considered. BMI categories and waist circumference should all follow World Health or WHO guidelines, also noting ethnic and adolescent ranges. Consideration should be given for Asian and high risk ethnic groups, including recommended monitoring of waist circumference. All women with PCOS should have blood pressure measured annually or more frequently based on global CVD risk. So these are the metabolic screening. We go for this, and we shouldn't forget additional strategies to incorporate into the nutrition care process, specifically evaluating for signs of binge eating disorders, requesting vitamin B12 testing for older adolescents and young adults who have been on high doses of metformin for a long period of time because it alters the level. Then comes the emotional well-being and PCOS. There is an increased risk of anxiety and depression symptoms in adolescents diagnosed with PCOS. These girls will benefit from appropriate screening and management, and emotional well-being is a poorly evaluated area in adolescent girls with PCOS because this is neglected part. And eating disorder with and negative body image are other common disorders in PCOS patients apart from bipolar disorder. Anxiety and depressive symptoms should be routinely screened in all adolescents. In the screen for these symptoms, other aspects of emotional well-being is positive. Further assessment or referral for assessment and treatment should be completed by suitably qualified health professionals. So factors including obesity, infertility, and hirsutism need consideration along with use of hormonal medications in PCOS as they may independently exacerbates depressive and anxiety symptoms and other aspects of emotional well-being. So adolescents at risk of PCOS are menstrual irregularities persisting beyond 2 to 3 years post-menarche and sudden gain in weight which is not manageable, moderate to severe hirsutism and acne not responding to proper treatment. So these are the exercises they should do. Treatment of menstrual. So treatment options, everybody knows it's menstrual irregularities, treatment of hirsutism and acne, treatment of metabolic derangements, if any, and obesity, anxiety disorder, lifestyle modification is the answer for these PCOS girls. Local treatment, oral contraceptive pills, anti-androgenic treatment, insulin sensitizers, and combined treatment for any other things. Lifestyle intervention, like once we had a very good CME on PCOS, so the answer was only lifestyle changes. A systemic, for the adolescents mainly, review showed that lifestyle modification as the first line of treatment in young patients with PCOS can improve their clinical, hormonal, and metabolic findings. This review concluded that caloric restriction and weight loss can directly improve disease outcomes in PCOS patients, although the effect of diet composition has not yet been well elucidated. So diet, exercise, and behavioral therapies. So diet is very important. You have to modify your diet. You have to be on the healthy side. So high consumption of unhealthy diets, these are the bad eating habits that they have to leave, these adolescents, and especially in this era, high consumption of fatty and salty food, high consumption of unhealthy snacks, then sugar-rich foods, low consumption of healthy foods, low consumption of dairy products, fiber-rich foods, meat, bean, fish, and seafood they don't like to take, inappropriate behavioral habits, lack of concentration and consumption of large meals, skipping the meals and going on arbitrary diets, whatever they want, they take. The results of the present study showed that the adolescent girls with PCOS consume a small amount of healthy foods such as fiber-rich foods, meat, beans, fish, seafood. Most overweight and obese adolescents with PCOS have little physical activity, skips the meal and eat fast and consume large amount of food. Lifestyle scores were lower in the PCOS group in the field of physical activity, and overweight and obese adolescent girls with PCOS are heavily influenced by their friends and peers in choosing fast food and snacks. So when we talk of the adolescents, we really have to look after their peer pressure. They only listen to the friends, what they say. And to conclude, overweight and obese adolescent girls with PCOS have inappropriate food habits, which can lead to complications such as infertility. Hence, the necessities of designing and performing the required interventions to change the food habits, control the symptoms and complications of PCOS, and finally improve the reproductive health of these girls. Overweight and obese patients they don't differ significantly from slim girls in terms of the energy, animal and plant protein intake. These were just a study, and higher FAI value was observed. We won't go much details for this. Advantages of high protein diet. Everybody knows that the beneficial effects of higher protein diet is very much. Protein increases the satiety, possibly due to the increased production of this, and then hypocaloric diets improves BMI, free testosterone levels. Evidence does not support a specific diet composition or physical activity regimen to promote weight loss and associated improvement in health measures. Compelling evidence supports employing an interprofessional team, including a nutritional professional. But although they ask which diet works the best, a low glycemic food diet and specific macronutrient goals, then family-based approach if the family is supportive, so remote intervention components and a structured multifaceted intervention. So these were the conclusion of this study. These are other study activities, physical activities. The girls, they like to do dancing, running, Zumba, swimming, hiking, playing. So this way they can take care of this. And the smart approach, the specific, measurable, achievable, relevant, time-limited goals could include 10-minute bouts, progressively increasing physical activity 5% weekly up to the above recommendations. So this was the approach. Then behavioral therapy, self-monitoring, self-sustaining, stick to the goal. This is very difficult, although for the adolescents. And some small, since medical therapies may take at least 6 to 9 months before any benefit is perceived, local therapies may be helpful in that interim period, as these interventions can significantly improve quality of life, like laser, electrolysis, waxing, bleaching, because they don't look good. And then we have insulin sensitizers. These have some role, not very much in use. Metformin is commonly used in young females and adolescents with PCOS as first-line medication, with or without combination with OCs and anti-androgens. This drug can regulate menstrual cycles and decrease hyperandrogenemia through improving insulin sensitivity. So these are the results and conclusions. So these are for study purpose. Inositol, myoinositol also, they are just tried, and this DCI also works very well. So I won't go into all the details of the studies. So there are many combination drug which once it doesn't they don't respond, we have got many types. So management of insulin resistance is also a lifestyle modification, insulin sensitizing agents and anti-androgens. Then these are the other drugs. Oral contraceptives also helps a lot. And how do they work? They work by decreasing androgen concentrations, increase SHBG concentrations, regularize menses, prevent pregnancy, and protect the endometrium. So point of concern with OC pills, worsening carbohydrate metabolism and lipid profile. So I'll tell you that for the young adolescents, we don't prefer much of the medication, the counseling part, the diet modification due to the insufficient studies conducted on adolescent patients. A definitive conclusion about their long-term risk and safety, especially about breast cancer and cardiometabolic disorders, cannot be drawn on this. So these are the points of concern with OC pills. So I will skip these few slides because they are much in detail. And then do's and don'ts, as everybody knows. So we exclude other causes, keep high index of suspicion, clinical examination. Once you face vitamin PCOS girls, and don't label her as PCOS, as we had already discussed. We shouldn't overdiagnose or we shouldn't even underdiagnose. What do we learn so far is lifestyle modification is the key treatment. Freedom from alopecia and hirsutism along with obesity gives confidence to these young ladies. OC pills can be used to treat menstrual irregularities and hirsutism. Perception of OCP should be based on WHO principle and prescription, and girls intolerant to OCP could be given insulin sensitizers along with lifestyle modification and anti-androgens to be added only if OCPs are not working in long term. So adolescent PCOS is a complex thing. We have to treat it very gently. We should start with the 0.2, gradually counsel her, tell her what best she can do, diet and exercise. If it all fails, then we go for the investigations and treat her accordingly. But we need to be patient and we need to counsel the adolescent and their parents together. And so they can go for these other things like yoga, weight loss, and proper thing, non-interfering things and conservative items. So thank you very much for the patient listening. So this is all about what I have to say.
Thank you so much, Dr. Supriya. Yeah, definitely. It was a great session where you have listed all the points why adolescent PCOS should be diagnosed. And in today's world, when the adolescent girls come to our OPD, we really, with irregular menses, we really know that they might be having PCOS. And they already come with a lot of investigations. I'm really surprised. They come with the AMH, they come with fasting insulin, they come with all these in the FSH, LH means those. Doing in the peripheries, practicing in the peripheries, they will do all the investigations to diagnose PCOS. Whereas we can just clinically diagnose the PCO, right? So we should really pass on this message, not to investigate so much for investigating diagnosing a adolescent PCOS, and we should really focus on the diet and lifestyle rather.
Yes,
It
very
was a
informative
great.
lecture by Dr. Supriya. As she has already rightly pointed out that AMH is not required for diagnosis of PCOS in adolescent and neither ultrasound is required. And nowadays we are also getting so many cases of lean PCOS. So we do exercise them a lifestyle, we do advise them a lifestyle change, but many times it is very difficult to treat these lean PCOS adolescent patients. So thank you. Dr.
Thank
Supriya.
you. Thank you, Supriya. Now let's go on to the next session. Yeah.
Yes.
Now after adolescent, we are coming to the fertility challenges. Yeah, please share the slides.
CV, yeah.
Chairperson slide. Yeah. Not here.
Sahiti?
Sahiti? She's not here. Do you have?
Shield connected. Who's here with the from Shield?
We are having some technical glitches.
Today she is having some problem, I think.
Hmm.
Then so in the second session we have as chair Dr. Mala Srivastava. Madam is ex-vice president ISOPAR of a national ISOPAR. And then one sec, I'll just see from here only. She's unable to.
Yeah. Trying to take it to my.
Yes, madam.
Hello.
Yes, yes. Are you going to share?
She's here. She is logged in.
Yeah, somebody spoke from them.
Yeah, Shield people, please share the slides.
Yes, ma'am.
So this is the second session and we have our speaker, Dr. Yusuf Latif Khan, sir, and he is the past secretary of CEPOG, and he will be speaking on fertility challenges. And to chair the session, we have Dr. Mala Srivastava. Just give the sheet CV. Madam is Head of Gynae Oncology Unit, Senior Consultant and Professor JIPMER, Gynae Endoscopic and Robotic Surgeon, Sir Gangaram Hospital, New Delhi, Vice President ISOPAP 2324. And then she is also the past president AOGD. She was in 2020 and 21 in a huge society. She was the president, and she has special area of interest in gynae oncology, gynae endoscopic surgery, gynae robotic surgery, fellow of minimal access surgery. She had been in many organizations and she is the member of many societies. And Madam has many, many accolades to her credit. So, Madam, I welcome you to chair this session. And the second chairperson is Dr. VP Jyotsna. She is the consultant obstetrician and gynecologist laparoscopic surgeon at 9M by Ankura Hospital for Women and Children, Hyderabad. MBBS graduated from JIPMER Pondicherry and MD she completed from same place, JIPMER. And then training in advanced laparoscopy 2007, Paul's Hospital, Kochi. She has done from there and course in fertility enhancing surgeries. So you're the apt person for this session, Madam, 2019, and then Secretary of ISOPAB Hyderabad chapter. So welcome both the chairpersons, and may I request you to kindly introduce the speaker.
Thank you, Dr.
Supriya, for your
Supriya.
kind introduction. It's my pleasure and privilege to introduce the star speaker of the evening, none other than Dr. Yusuf Latif Khan. Sir is a professor of obstetrics and gynecology in Rashid Latif Medical College. He obtained his fellowship in obstetrics and gynecology, FCPS, from College of Physicians and Surgeons of Pakistan in 2003. Most active member of ART team at Life Clinic Hamid Latif Hospital, actively involved in running of Hamid Latif Hospital and clinical care of the patients undergoing ART treatment in Life Clinic and Hamid Latif Hospital.
Thank you, Madam.
Sir, you are such a decorated person and such a senior clinician. It's a pleasure to listen from you this evening, sir.
Thank you,
Welcome,
Dr. Thank you, Dr. Malik, for the kind words and introduction. Can I share my slides, please?
Yes, please.
Sure. Okay. And
Yes,
I
yes.
hope you can see them.
Yes.
Yes, we can.
All right.
We can see your slides.
So, namaskar, everyone, and thank you very much for inviting me over for this, especially the Indian Society of Perinatology and Reproductive, and of course, our dear friend Dr. Lakshmi. And she just messaged me, and it was indeed, honestly, a proud welcome to be here on this time on this forum. So when we talk about PCOS, I think every gynecologist has seen one. I don't know how many, but probably would seen at least more than one in their practices every day. And we need to understand this thing that this PCOS is one of those unfortunate diseases which does not have a cure, but we can kind of control it like blood pressure and diabetes and hypertension, but we cannot unfortunately cure this completely. So this is one of those things which the unfortunate woman has to understand, and she has to live with this. Okay, she has this, but if she kind of manages this and maintain it, then she can have as normal life as anybody else in this world. So I have a disclosure, just a disclosure. I'm on the board of advisory board of an Abbott Pharmaceutical in Pakistan, but I don't think so it has anything to do with this presentation. So all of you, I bring you greetings from Lahore, Pakistan. This is one of our hospitals where I work. And this is our IVF center, which was kind of established in 1984. We were kind of the first ones which we started off. My father actually started this off in 1984 and was one of the first one in Southeast Asia. These are two of our medical colleges, and we do have charity hospital with them in right by next time. So it all of this PCO was, as we all know, started with Steen and Leventhal, which was described back in 1935. That was about almost more than 80 years back when it all kind of came into somebody said, okay, this is a syndrome. And up till now, after so many years, we still actually have not clearly know how the pathophysiology it is done. And unfortunately, up till now, there are few definitions, but there's not a universally accepted definition for this PCO, which is kind of agreed by all. There have been three groups, one in 1990, NIH, and as my previous Dr. Supriya beautifully had an excellent lecture, and she mentioned this Rotterdam criteria and how to manage that. They came out with the consensus in 2003, and then again in 2006, an Androgen Access Society said something about describing this PCO. And if we take all these 2-3 criterias and we see their prevalence in general public, for the Rotterdam criteria, about 5 to 20%, 5% to 20% of patients, they are PCOS. While for if we take the NIH criteria, it comes down to almost half, between 5 to 10%. And if we include the Androgen Access Society, then general population, it's between 10 to 15%. But the most widely used criteria, and we, especially I think in our part of the world, India and Pakistan, this instance might be, if you put a Rotterdam criteria, that it might be higher than 20%. So again, my previous speaker, Dr. Supriya, has excellently mentioned all these, and I'm not going to focus on only the subfertility part for this PCO issues. We all know about the consequences, which is also very important. If somebody comes to you, especially in adolescence, they have the tendency, if it is uncontrolled or unmonitored, they can have this hyperplasia leading up to cancer. And now the sleep apnea part has also come up, which can be a diagnosis or the consequences of PCO, non-alcoholic fatty liver, mood disturbances, obesity, hirsutism. So they all are kind of a syndrome which once a patient comes to you, you do need to keep all these things in the back of your mind before you start treating them, because we don't have to treat the disease, we have to treat the patient. That's one of the common things which have been taught to us from the day when I started my residency and training in ops and gynae. So these are kind of all the pathways, which I don't think so I have to go through this insulin resistance one or this one for the hypothalamic pituitary dysregulation and the rise of androgens in the body. But this is the part where I think I'm going to focus, and that is the subfertility, which is defined to achieve a clinical pregnancy after 12 months or more of regular sexual intercourse in women 35 years of age. I think the most important aspect of this definition is 35 years of age, which we need to keep that in mind. Because if she's more than 35 years of age, then we can't just wait for a year or so before she comes back to you again for some infertility part. And for that, more than 35, I think 6 months or more should be good enough where we start investigating, and we should start it early. As American Society of Reproductive Medicine say, the subfertility affects nearly about 12% of couples worldwide. And if they are combined with PCO, then this percentage, as you can see, goes as high up as 70 to 80%. So what ASRM has recommended that for infertility, when the patient comes in, you don't have to wait for, irrespective of her age, you don't have to wait for about 12 months or so. If she falls into criteria of PCO, then you need to start working or investigating her for the next, after about 6 months or so. We know that apart from PCO, if somebody comes on the other causes of subfertility should be kind of ruled out, which includes probably the tubal patency, the semen analysis, her and ovulation status, and all of these have to be to be put on aside before we kind of label the PCO or the polycystic ovaries to be the cause of her fertility issues. So when it is done, so do remember that we start with non-pharmacological therapies, which means the general principle of therapy is that we have to optimize. This is very important, her health first before commencing treatment for subfertility. You do remember that our only objective is not to get her pregnant, but we need to have a healthy live baby at the end of those 9 months. And we just giving her a positive beta HCG will not resolve her solver problems. So to have that optimized health first, she needs to reduce metabolic adverse effect of PCOS. We need to sense of better physical well-being in this woman, and that can only be done by exercise with dietary changes and for caloric restriction. I do remember one of my patients who comes in with a PCO and she wanted to conceive, and I requested her, okay, let's start with nutrition, and this is what you need to eat for breakfast, and this is what you want to have for lunch, and this is what you I would like you to have for dinner, and in between this is the food or the things which you can high fiber can take it. And she comes back to me and asks me, sir, do we need to take this food which you told before my breakfast or after my breakfast? So I was kind of stunned and could not. I said, I think for me, I said, okay, the best thing for you is to go to a nutritionist and get an opinion from them what and how you should eat that. So involvement of other team members also is very important to tell them how to go about that. We do know that the more the weight is, there's a high risk of developing type 2 diabetes, and of course, overweight will learn. And this is actually a very kind of, I figured it out that even losing just about 5% to 10% of your weight improves your ovulation as well, and a lot of other associated uh, problems which are associated. So even just a target of only 5% does really help for a patient for an general health and for pregnancy as well. So in obese PCO population, weight loss itself, regardless of the modality, be it medication or gastric bypass, which is coming in a new thing. I'll come back to this a little bit later. Diet and exercise has been associated to improve pregnancy rate as well as decrease hysterectomy because of the decrease of androgens. So once these things we try, and if they don't work very well, or we can't just wait for about a year or so before they start kicking in. So in probably I as a personally and with the literature, I think the sports make after 3 months or so, then if it is not kind of working very well, we need to add on with the pharmacological therapies which are available in the market. So the objective of these pharmacological treatments are to counteracting hyperandrogenism, managing endometrial effects of ovulatory dysfunction, and of course, improving metabolic status and treatment of subfertility via ovulation induction. I'm going to focus on these ovulation induction part because my talk is related to the fertility and these kind of issue. So for the first thing we start off is metformin. Metformin at the time when we were kind of in the training process was supposed to be the recommended drug, but but now it is not at all recommended the first line for treatment of fertility. Yes, for other features of as Dr. Supriya said, okay, they are effective, but not for fertility. It's not the first line of drug which was used, but it is used for it's largely effect on metabolics. It does improve the ovulatory function, and it only works for fertility when it is combined with clomiphene citrate. And then it is might be considered, but still the literature is not very popular about saying that insufficient evidence of an increased live birth rate with only these metformin and CC. So coming to CC, clomiphene citrate was the most widely used first-line therapy before the advent of probably letrozole. So it's an oral anti-estrogenic. What it does, it raises your FSH, and as a result of that, that increases the follicular development and the number of follicles. The doses which we prefer to give it, we start with the 50 milligram for 5 days, either starting from 2 to 6. That's our favorite, generally the thing. Otherwise, it can also be given for 5 days from starting from the menstrual day from day 3rd to 7, and so from 5 to 9 as well. It is recommended to start this by step-up approach, which means you start by 50 milligram in one cycle and you look at the ovulation. If it is not happening under the ultrasound, and so we increase the dose to 100 in the next cycle, and if it doesn't happen or the number of follicles which you want that are not achieved, then we can always increase to the maximum dose of 150 milligram a day. Again, it is given for 5 days only. But for giving this, then you need to also consider the starting date does not have to be in everyone for 50 milligram. It also depends upon the weight or the weight and BMI of the patient as well. But with all these, do remember that it has a high risk of multiple births and their complication associated with all this. So this was multi-centered. I'm sure a lot of people have heard about this PPCOS1 trial in which they gave clomiphene citrate and compared metformin with that. So what they figured it out that the results, of course, alone of metformin was not good enough, and alone of clomiphene citrate was working, but not as good enough. But if we combine metformin with clomiphene citrate, as you can see, the combination they give the best results of the pregnancy in a PCO obese patients. So once the letrozole came in, it's some kind of aromatase inhibitor. Now it is one of the considered to be the first line drug for fertilization or ovulation for the PCO patients. It is very effective for ovulation. It is again administered for 5 days, just like the same as CC. And the starting dose is generally from 2.5, and it can be increased up to stepwise the same way as CC to 7.5 milligram in a cycle. This PPCOS, the second studies, then they came up and then they kind of compared the clomiphene as well as letrozole together of them. And as you can see with these results, the fertility rate was better with letrozole than clomiphene. And as a result, the letrozole now is considered to be the first line of therapy for anovulatory or in PCO patients. And this is also important. I read it there that the combination of letrozole and clomiphene may act synergistically to improve ovulation rates in women with PCOS. So the combination of giving them the both at the same time for the 5 days, but the number of patients which they use for the surgeries, I think, were not more than 25. So it is not actually recommended, but still in the trial basis. But you can trial in one of those patients in which you fail to get an ovulation done. These are the graphical representation or dramatic representation of letrozole and clomiphene, how they work. This is also kind of an important one here where we comparing the letrozole and the clomiphene. This is in all the patient, and as you can see the BMI being raised, the success rate of letrozole is much better than this clomiphene part. So that is one of the reasons that the letrozole is the first line of therapy in especially the obese patients. If they're both not working, then they move on to the gonadotrophins. But the problem with the gonadotrophins, of course, is the multiple pregnancies, and especially in PCO patient, the increased risk of OHS. And I'm sure, especially the IVF experts, they have a lot of experience using those, and they do have an experience of having OHSs, and it is a nightmare for all of us who are doing IVF and encountering this OHS. Well, because we do remember that those patients are healthy, good patients, and they come for fertility pregnancy and then ending up with OHS and going up to an ICU settings who do that. And so that's one of the concerns whenever we're going to advise all this. There were times when this surgical intervention was done, and back in 1935, Steen and Cohen, they described ovarian wedge resection when they used to do the laparotomy and then just chop off the half of the ovary away and doing that. They had a very good results for that, but I think in modern times, there is no role of this ever at all right now. Then in 1984, then this was described of LOD came up. It was kind of very popular initially, and it was recommended as a second-line therapy, especially in those patients who were resistant to clomiphene at that time because only clomiphene was available. But what they did in LOD was they make small, now it is recommended to have 4 holes at 40 watts for 4 seconds to each ovary. They do that, and then they kind of cool them out with saline. But with the invention of these gonadotrophins and other drugs, but I am not very sure it is either not very first line or second line, or actually my favorite to have it done. We do a lot of laparoscopies, surgeries do that, but doing LOD, I think in the past, probably maybe 10 years or so, we've already probably done 1 or 2 cases. That too was very kind of discussed and then do that. And then why we don't do that? Because there is always a surgical risk, and there's a risk of adhesion formation and always thermal damage and always premature ovarian failure. So all of these things have to be kept in mind before you advise anybody how to proceed and what to do. So these are in table, you can see the advantages of going laparoscopic drilling by gonadotrophins, but there's also surgical risk of inherent with laparoscopies and post-operative adhesions. And of course, with the advancement of these gonadotrophins and other drugs which coming in, I don't think so. Okay, LOD has much of a place here, but it can be done in selected few cases where you think it can be done. So if those patients who have kind of failed with gonadotrophins in this and IUIs, and then we move on to IVF for ART patients. So in vitro fertilization for the treatment of anovulatory polycystic ovarian syndrome is a third-line treatment for infertility or subfertility. And IVF may be offered after failed induction, as said, failed ovulation induction with oral agents or gonadotrophin treatments. So these are the different gonadotrophins which are kind of available in market, which are HMB purified. Now the use of recombinant and purified FS such as more rather than the one which we use HMB. And of course, ACG, GNR, we do have GNR agonist as well as antagonist. But you do remember that the issues with ovulation induction is inadequate sometimes responses, and most deadly is the ovarian hyperstimulation. So again, as I kind of mention all this, I'll skip this. So PCOS patient undergoing IVF are generally, they have good prognosis if they come into a certain good age and they're diagnosed early and treated earlier to achieve a live birth. Because during IV stimulation, the difference is that they have longer stimulation protocols regimes. They have larger number of antral follicle counts. They have larger number of oocyte retrieved. They have larger number of embryos we get, and of course, excessive embryos means that we have cryopreservation, and of course, with that means we can utilize multiple cycles, and every time they don't have to go through this stimulation regime again and again if we have the frozen embryos available. And secondly, the advent of IVM has also come into market. Unfortunately, in Pakistan, we have not started doing that as yet. I'm not sure about India, how many people are doing that. But I think to decrease the chances of ovary hyperstimulation, IVM, in vitro maturation is the thing. And that kind of saves a lot of patients, a lot of price as well as advantage to the patient. So PCOS patient may require they do require relatively high dose of gonadotropin because the stimulation regime is slightly longer and because for them to advance, and that is because of underlying hyperandrogenism. And the increasing gonadotropin, you need to be cautious, as I said before, and should be monitored very, very closely, and the risk of OHS should be kept in eye because they are prone to developing that's ovarian hyperstimulation syndrome. Okay, we do have GnRH agonist as well as antagonist, and both of them can be used for in IVF patients for those who depending upon what do you want to use them for, and both agonists and antagonists are widely used, as I told you before. They are basically the objective is to induce follicogenesis, time oocyte retrieval, and prevention of endogenous LH surge. GnRH agonist protocols, they can be used for short protocol as well as for long protocol. Long protocol, they have been there since 1980s, but recently we have kind of moved into the shorter protocols more because of their results. Because better IVF labs, their medias, and their growth. So shorter protocol is much more better. These are different generic and of course the pharmaceutical names of different agonists as well as antagonists. So as I mentioned, two protocols, the primary, the long and short, depending on what you want to do. I don't want to go into detail when to start. Of course, this long protocol started on day 21 of the previous cycle, and then GnRH and agonist as well as gonadotropin, and then HCG trigger is done. In the short, we start on the day 2 or 3, and then of course the same way the HCG, and then of course the oocyte retrieval. PCOS patients generally they are good responders. They are not one of those who does not respond, but the response has to be monitored as well as we have to see how much the FSH or whatever you're going to give, going to do that, that you don't run into a chance. There was a study in which they gave us 20% incidence of OHS in PCO patient compared with 7% incidence in non-PCO patient. So that means about 13% increased chances in those patients who were not PCO. Those who were PCO. So that makes a lot of difference. I'm not going to go into details of this. These are again template of the diagrammatic of this representation of antagonist protocol starting and we do understand when there's 3 or more follicles of 18 millimeters or so, then you can give the HCG and do that. So we know, again, I'm coming back to ovarian hyperstimulation, where when you trigger them with HCG, it got flares up. So we have to understand when to and not when to give agonist trigger or when to give an HCG trigger. PCO patient represent a high responder group, as I told you before. The serum level of estradiol and progesterone are usually markedly elevated. Endometrial involvement is negatively affected by the supraphysiological hormone level. And this is important, elevated progesterone level on the day of HCG triggers are negatively associated with live birth rates in fresh cycles. So what does this all mean? That means it's not necessarily we transfer them on that cycle, so we move on to them freezing. All strategy in PCO patient is much better and the better results rather than freezing them or transferring them in the fresh transfer in those patients. But it also depends upon the quality as well as the number of embryos which you kind of have at the time there. In some cases, we need to add adjuvant treatment like metformin. Again, my previous speaker has added to that. it also decreases systemic insulin levels, which actually decrease androgen production PCO. And it might be beneficial for women with increased BMI because it helps to lose weight. And there is no set protocol depending upon what, but different people say different thing. And between 500 milligram 2 or 3 times a day, or maybe 850 milligram twice a day. But it has to be started about a couple of weeks before we start an IVF program. So we generally advise them to take it about 2 months, so they get used to this tablet, because they have it's nausea, vomiting effect kind of settle down before we start them with an IVF. We continue that with our regimes with that. And in some cases, we even continue that. One of the other challenges which we feel is that even though they get pregnant, these PCO patients, they have a high incidence of miscarriage, which is because of insulin resistance, hyperandrogenism, increased body mass index, and all of these should be targeted before we transfer them or before we start an IVF program. Again, the miscarriage part is that. And one of the interesting things which I found out was that because of aneuploidy is increased in PCO patient, which was 61.3 in PCO patient wide 47. But that is one of the reasons of doing this, what you call that miscarriage rate. And as well as for these patients, there's an option of PGT as well. That means we diagnose or we screen those before you transfer them. So but it all comes with a certain cost. The role of inositol and PCOS, again, the madam before me has also touched on that, but it is only in the experimental or clinical trials then, but it is not recommended in anywhere to be using them and how much we do that, because we don't know there's very limited evidence on their results and their clinical pregnancy and live birth. And of course, their safety for pregnant patients. Obesity and PCO, yes, of course, they are still, wherever it is done, yes, it looks nice, but they are not kind of very safe to be using them for each and every patient. Maybe bariatric surgery in selected few cases, because it does, depending on the patient age and all the baki BMI, if it does happen, but we have to wait for about a year after bariatric surgery before we can advise them for fertility treatment. I have seen a few patients who have conceived even naturally after having this bariatric surgery, but do remember that they have their own issue of doing that. So if we take a graph, the first time treatment is weight loss. It is very low cost. It is very feasible in our type of patient and the population where the cost does make a difference. Again, first line of drug is letrozole or the clomiphene with metformin. They're both not that expensive. Again, then moving on to then the cost comes in gonadotropins. Then ovarian drilling, I don't think so that should be there. But of course, doing this laparoscopically, it has complication and the cost. And the third is, of course, the last one is IVF. But remember that the IVF success also depends upon the female age. So it's rather waiting till she is about 38 or 40 plus years of age, then you advise her or refer for an IVF center. They should be referred there quickly. If you go by a graph, you can see that if it is diagnosed by polycystic ovaries, first of all, you optimize her general health side. Then the first line becomes letrozole or clomiphene plus metformin. If there is ovulation detected, then you can repeat these cycles again for about maybe 5 to 6, depending again. If she's more than 35 years of age and they can afford, then of course they can be referred for IVF program. If there's no ovulation with letrozole and CC metformin, then you move on to the gonadotropins. Again, if it works, ovulation is there, you repeat the cycle 3 or maybe 3 to 6 between them. Or if they can afford and age is more than 35, then you move on to the third line of medicine, which is IVF. So in summary, infertility associated PCOS is the most cases treatable. Remember that, but you remember that it is not curable. You can kind of maintain it or manage it, but you cannot treat it for lifelong. Counsel to achieve healthy weight before conception, which should be between 18 and 25 BMI. If that's what less than 17 is also does not make the healthy pregnancy. You need to also address all the underlying medical condition, impaired glucose tolerance, and the preconceptually. Aromatase inhibitors alone, as I mentioned first, is the first line drug, and the combined therapy with metformin CC is also help, especially in those morbidly obese patients. And for those who are clomiphene or letrozole resistance patient, addition of metformin, or maybe moving to aromatase, laparoscopic drilling, not my favorite, but still there, gonadotropin, and moving on to IVF. So again, I would like to thank everybody on this portion, and especially Dr. Lakshmi for letting me in this part of this and giving this opportunity. And thank you for your patient hearing. Thank you very much, madams.
Thank you, Dr. Yusuf.
Yeah.
That was a very lucid presentation on fertility challenges, and you rightly pointed out the holistic approach of first tackling the lifestyle modification and controlling the weight, and then going ahead with the cycles. However much we are under pressure to treat an elderly woman with PCOS as early as possible, I think that weight management should take precedence over everything, because once she does conceive with all your wonderful expertise, the challenges for the obstetrician begin. So thank you so much. I think a lot of people are even putting women on semaglutide now for this weight management. Here in my city, I see a lot of women coming with prescriptions for semaglutide from the endocrinologist.
But still, the evidence does not kind of support it as such. But for fertility, if you tell a patient to hang herself upside down, she will do that. So, yes,
excellent talk, Dr. Latif. It was an excellent talk, and definitely you've given an insight into how to increase the fertility of the patients of PCOS. As everybody is saying, that lifestyle modification, diet, and exercise has to be continued besides the medicines. And that's a very important part that the patient should understand. Patients feel that only by giving medicines, they will improve. They have to understand that lifestyle modification and weight reduction, as well as exercises and nutrition, these all go a long way in supporting the management of PCOS. That's that information we should transfer to our patients, which they find very difficult to follow. But it was an excellent scientific deliberation from Professor Latif, and we all really gained a lot by it. Thank you very much, sir.
Thank you. Thank you so much, Latif. Just on one message, WhatsApp message, you agreed to come and deliver this fantastic, wonderful, informative talk. Thank you so much.
Pleasure, Dr. Lakshmi. It was always a pleasure. Thank you very much.
Thank you, Dr. Lakshmi, for having us here. Thank you so much, Dr. Latif. Okay.
So thank you. We are over with the second session and the wonderful talk by Dr. Yusuf Latif, sir. And now we move on to the third session. Third session is the metabolic disorders. The topic of this session is, and the speaker none other than Dr. Lakshmi Shikhande, madam. And to chair the session, we have Dr. Chandra Mansukhani, who is the gynae-endoscopic and robotic surgery adolescent health. She's interested in adolescent health. She is the senior consultant in charge of adolescent clinic at Sir Gangaram Hospital. She is the treasurer Narchi Delhi branch, treasurer IMS Delhi branch in other several years, joint secretary OGD, secretary of Narchi Delhi chapter. She'd also been the vice president ISOPAP Delhi chapter and vice president IMS Delhi chapter, editor of AOGD and president ISOPAP Delhi chapter till date. So from 2021. Welcome you, Dr. Chandra. Madam, are you there?
Can't see her.
So the second chairperson is Dr. Sarita Kumari. She is a consultant at Tata Main Hospital, Assistant Professor Manipal Tata Medical College. She has got many academics to her credit, worked in ICMR malaria research project in pregnancy, training in collapse surgery. She has special area of interest in endoscopy and gynae oncology, given talk, has invited faculty so many places. Recipients of so many awards and has several publications to her credit. So I welcome you, Dr. Sarita, and I'll request you to kindly introduce the speaker, Dr. Lakshmi Shikhande.
Thank you, ma'am. It's great honor for me to introduce Lakshmi, ma'am. I am really feeling privileged to introduce Lakshmi ma'am for the talk. Madam is Medical Director Srikhande Fertility Clinic, Nagpur, Maharashtra. Madam is past President Nagpur OBGY Society and past President Menopause Society, Nagpur. Madam is immediate past Chairperson ICOG and she is National Corresponding Editor of Jogi. She is National Corresponding Secretary of Association of Medical Women of India. And she was President ISOPAB with Vidrawala chapter from 2019 to 21. And she was also the chairperson IMS Education, and she was the Vice President Foxy in 2012. And she is currently chairperson Fertility Enhancement Committee ISOPA, and she is the member of SAFOG Education. And Madam has several national and international publications. She had 42 national and 21 international publications. And Ma'am has received several awards. She received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. Madam has received several awards from like Nagpur Ratan Award, Bharat Excellence Award, Mehru Dara Hansotia Best Committee Award. Ma'am, it's a great pleasure for us to hear you.
Thank you. Thank you so much, dear, for your kind words. Yeah. So may I share my screen? Yes. So I'm so happy to be the last speaker here because the theme of our webinar today is PCOS across the life cycle. So you have heard how to manage a case of adolescent PCOS from Dr. Supriya. You have also heard the fertility challenges from Dr. Yusuf Latif. And now it is the metabolic syndrome in PCOS, which is the prevalence of this metabolic syndrome is as high as 33% in women who are suffering from PCOS and is associated with long-term consequences such as cardiovascular disease, type 2 diabetes, cancers, sleep apnea, and psychological problems. And I'm so happy that both my previous speakers, they touched upon this aspect of PCOS in their presentation. Because conventionally, management of PCOS, whenever we talk, it is usually focused on infertility, anovulation, hirsutism. But now there is need to increase the clinicians' awareness about the metabolic syndrome in cases of PCOS. Because the enormity of the health burden of this metabolic syndrome means that accurate identification and timely intervention are extremely important. So what is the late sequelae? We are all worried about PCOS. She is 7 times more prone to get type 2 diabetes, 4 times more prone to have hypertension. She is more prone to have dyslipidemia. She is more prone to have endometrial cancer. Pathophysiology, everyone knows, so I am not going into the details, but we all know that the insulin resistance and its consequent hyperinsulinemia is central to the pathogenesis of PCOS. Insulin regulates the metabolic and mitogenic pathways that function independent of each other. And that is why this might explain the paradoxical insulin sensitivity patterns which are seen in different tissues. For example, we see resistance in peripheral tissues and retained sensitivity in the ovarian cortex. Metabolic inertia to insulin has been attributed to a post-binding defect in the insulin signaling pathway, which is caused by abnormal serine phosphorylation of the insulin receptor. And despite extensive data supporting the role of insulin resistance, it still remains unclear whether the association between PCOS and insulin resistance is causal, propagative, or merely coexistent. So now let us see its effect on atherogenic dyslipidemia. In adipocytes, insulin resistance leads to the increased shunting of free fatty acids from fat tissue to the liver. These free fatty acids, they induce hepatic synthesis of very low density lipoprotein, resulting in elevated triglycerides and apolyprotein B, and decreased HDL. These alterations in lipid parameters, they lead to atherogenic dyslipidemia. PCOS is associated with chronic low-grade systematic inflammation, which mediates insulin resistance and it accelerates the atherogenesis. Besides genetic abnormalities, obesity and a high glycemic diet are also known to induce pro-inflammatory cytokines such as tumor necrosis factor alpha and interleukin 6. Now coming to the obesity. Obesity, it is known to perpetuate PCOS. It most likely results from the combined effect of genetic predisposition, poor diet, and a sedentary lifestyle, thus compounding the pre-existing metabolic derangements. Hyperinsulinemia and the increased responsiveness of the ovarian theca to insulin causes an increase in the levels of free androgens, and hyperandrogenemia increases a person's predilection for central adiposity and it worsens the insulin resistance and dyslipidemia. Now, what about hypertension? In obese individuals, hypertension is linked to the potential of sympathetic outflow and the renin-angiotensin-aldosterone system, resulting from increased levels of insulin and free fatty acids. Concomitant vascular endothelial dysfunction also contributes to the development of hypertension, and analyzing all available data on the etiopathogenesis of PCOS, it is evident that a paradigm shift has taken place in our understanding of metabolic syndrome in PCOS from mere ovarian dysfunction to a multisystemic, multifactorial aberration with far greater metabolic consequences that initially were implicated. Now, the effect of insulin resistance on cardiovascular disease. The one meta-analysis demonstrated that in women with PCOS, the risk of coronary heart disease and stroke is doubled. Despite adjusting for body mass index, there was a 55% increase in risk. Subjects with metabolic syndrome are 3 to 6 times more likely to develop CHD with a 12% increase in mortality. Where metabolic syndrome coexists with PCOS, one would expect this risk to be significantly higher. Large-scale prospective studies that evaluate long-term outcomes are required to assess the magnitude of the impact of metabolic syndrome with PCOS on cardiovascular disease. Coming to diabetes, metabolic syndrome confers a 5-fold increase in the risk of type 2 diabetes, and PCOS has been identified as a significant non-modifiable risk factor. Women with PCOS with baseline normoglycemia, they have a more pronounced risk of developing impaired glucose tolerance, and up to 16% of women with PCOS, they convert to IGT per year. Women with baseline IGT have a 2% risk of progressing to type 2 diabetes mellitus per year, and over 6 years, this risk may be as high as 54%. A meta-analysis on the impact of PCOS on reproductive outcomes has shown a 3-fold increased risk of gestational diabetes. Now coming to the cancer, we all know that PCOS is associated with an increased likelihood of endometrial cancer. However, it is difficult to ascertain the independent effect of PCOS because of the additive influence of diabetes, hypertension, obesity, chronic anovulation, and hyperestrogenemia on the development of endometrial cancer. There is no strong association between PCOS and ovarian or breast cancer. Metabolic syndrome has been associated with an increased risk of endometrial cancer, that is odds ratio 1.6, and a higher incidence of pancreatic, postmenopausal breast, and colorectal cancer. In this study, the odds ratio was 1.5. Poorer cancer outcomes, increased recurrences, and overall mortality have also been linked to the metabolic syndrome. Now coming to the obstructive sleep apnea, which Dr. Yusuf Latif was talking. PCOS is associated with up to 30-fold higher risk of obstructive sleep apnea and a 9-fold increase in excessive daytime sleepiness. Insulin resistance has emerged as a principal predictor for the risk of obstructive sleep apnea, independent of the elevated testosterone levels and obesity. The presence of OSA in metabolic syndrome in turns worsens insulin resistance and cardiovascular outcomes. So women should be screened for and they should be counseled about snoring, daytime sleeping and fatigue, and they should be offered interventions when necessary. What about the psychological problems? The prevalence of depression is higher in women with PCOS than the general population, with increased severity of symptoms. And this association is independent of body mass index. These women are also more likely to develop anxiety, eating disorders, and dysfunctional relationships. Metabolic syndrome is associated with depression, mainly with neurovegetative features such as fatigue. Although inflammation has been linked to the development of depressive symptoms, the precise mechanism have yet to be elucidated. Since these factors significantly affect quality of life, it is essential to screen women for symptoms and to refer them to specialists when required. So now, how to diagnose the metabolic syndrome in PCOS? Remember, metabolic syndrome, it was first identified as a clinical entity with insulin resistance central to its pathogenesis. Thus, historically, the definition of a metabolic syndrome mandated the presence of insulin resistance for its diagnosis. Subsequent definitions, they included more composite criteria. For example, they included waist circumference as a measurement of central obesity. Multiple definitions for metabolic syndrome have been proposed over the years, reflecting a shift in the proposed pathogenic mechanisms and clinical implications. These are the various organizations which have proposed various definitions of metabolic syndrome. They are WHO, the International Disease Federation, the National Cholesterol Education Program, American Heart Institution Association, National Heart, Lung and Blood Institute, and Adult Treatment Panel 3. What are the diagnostic criteria which all associations have used? They are the high waist circumference, high blood pressure, high triglycerides, high glucose levels, that is fasting glucose, and low HDL. These are various organizations I have already described. They have come out. So NCP thing, any 3 of the 5 criteria. Most of the associations are saying any 3 of the 5 criteria except IDF, which is saying elevated waist circumference with any 2 of 4 criteria. So I will not confuse you with this slide. It's a very crowded slide, but going through the definitions of all the associations, the definition of joint interim statement, that is all these associations, they collaborated with each other to come out with a joint interim statement about the definition of metabolic syndrome. And now this simplifies its utility as a clinical tool and has emerged as one of the most commonly used definition. So JIS is saying any 3 of the 5 criteria. Now, screening of metabolic syndrome is very, very important because we all are seeing adolescent PCOS. We are seeing them in the reproductive age group. So a structured assessment for the early detection and management of metabolic syndrome, especially in women of reproductive age, would be of critical importance to the healthcare system so that it can be applied in the clinical setting. This assessment would need to prioritize risk, standardize the evaluation methods, and establish the frequency of further testing. A comprehensive evaluation of the risk factors for metabolic syndrome adapted from evidence-based guidelines from Australia and UK's RCOG I am showing you in this table. India, we don't have any guidelines, but this is how RCOG has said that you have to screen these women in the reproductive age group, ask the history of cigarette smoking, look for BMI, their waist circumference, blood pressure at every visit. Then you have to do lipid profile and oral glucose tolerance test, and they have given that if she is having BMI less than 25, you should do lipid profile and OGTT annually. If she is having BMI more than 25, then you have to do lipid profile and OGTT at every visit for women with a normal profile, and then every 2 years. For women with an abnormal profile or having high BMI, you have to do annually. So these are the guidelines given by RCOG. We can adapt it to our circumstances. Now, how to manage? With metabolic syndrome adding to this epidemic of type 2 diabetes, CVD, we have to institute early interventions, and targeted interventions is need of the hour. So the primary intervention for metabolic syndrome requires adopting lifestyle changes, which has been covered in great detail, that may prevent or slow progression to adverse events in high-risk individuals. In those who do not respond adequately to lifestyle modifications, secondary interventions can be considered, including drug therapy and bariatric surgery. So the lifestyle modifications again has been covered in great detail by Dr. Yusuf Latif. So they have to focus on diet. It is advisable to refer them to a nutritionist, and they need an exercise schedule as well. Now coming to the medical management for metabolic syndrome. Now remember, we all know that metformin improves the insulin sensitivity, and it has also been shown to decrease the fasting insulin levels, but this benefit was restricted to non-obese women with PCOS whose BMI was less than 30. There is no robust evidence for the use of metformin to merely ameliorate the insulin resistance associated with PCOS, and its use to combat the same in normoglycemic women is not recommended. Women with IGT who have a significant risk of conversion to type 2 diabetes, metformin can be considered for use in these women. Metformin has been used in incremental doses ranging from 500 to 1500 milligram per day. There is no consensus as far as the duration of treatment is concerned. Does inositol has any role in the metabolic syndrome management? Various studies have demonstrated that administration of DCI leads to decreased basal insulin levels and improved lipid profile, and it reduces the systolic blood pressure. So the preliminary data suggests that supplementation with inositol can be considered for improving a patient's metabolic profile, but more studies are required before its use can be standardized. Now, what about the anti-obesity agents? We all have Orlistat. It induces significant and sustainable weight loss with similar efficacy to metformin. Based on available evidence, Orlistat can be considered for the treatment of overweight and obese women with PCOS for whom lifestyle modifications are insufficient. The dose is 60 to 360 milligram per day divided between 2 to 3 doses. Extending this favorable effect to cardiovascular risk, Orlistat might have a role in the management of metabolic syndrome as well. However, further studies are required to assess the use of Orlistat in those women with PCOS and metabolic syndrome before it can be approved for therapeutic indication. Another anti-obesity agent is liraglutide, and the use of liraglutide is limited by the need of parenteral administration and the frequent occurrence of the GI side effects. Now we were talking about semaglutide. Remember, the FDA approved the semaglutide containing medication for chronic weight management in adults with obesity or overweight with at least one weight-related condition. So just for weight loss, it has not been approved by FDA. obesity has to be associated with at least one adverse effect, which is because of the obesity. Then yes, you can prescribe semaglutide and it is available in India also. What about the prescribing statins for metabolic syndrome? They seem to create a favorable metabolic environment. Their use is limited by certain risks, but yes, you cannot routinely recommend statins in cases of metabolic syndrome with PCOS, but apparent benefits of medical therapy must be weighed against the risk of potential adverse effects if you have to prescribe statins. Surgical management, again, Professor Yusuf Latif has told you about the bariatric surgery, that when other management strategies are failed, bariatric surgery may be offered to those who have class 3 obesity, that is where BMI is more than 40. Bariatric surgery may also be considered in women with class 2 obesity, that is where BMI is between 35 to 40, where with this BMI, she is having chronic medical conditions such as diabetes and hypertension. So these are the two indications for bariatric surgery. But all said and done about the metabolic syndrome, you all will agree with me that prevention is better than cure. In order to prevent metabolic syndrome, we need a multi-pronged approach, which should include behavior modification, dietary modification, increase in physical activity, and prevention of smoking and excess use of alcohol. So where to catch? We have to catch them young. Schools are the best. They offer an ideal medium for lifestyle interventions because the obesogenic lifestyle behaviors are less well developed in children and therefore they are amenable to change. So we have to target the prepubertal and adolescent girls as they are the future mothers. We have to catch them young. 42% of the girls between 6 to 10, they really wish that they should be thinner. So lifestyle modification is very simple. If we reach out to these young girls and we can teach them about the balanced diet and physical exercise. And what is the role of obstetrician? Because in our OPD, day in and day out, we are seeing cases of adolescent PCOS. We have the opportunity to counsel their mothers as well, because usually they are accompanied by their mother and father. Of course, we can reach out to the schools. But as an obstetrician, we are also dealing with the cases of pregnancy, and you have to here take this opportunity to counsel her about the long-term sequelae and about the metabolic syndrome, because it is our responsibility not just to treat that adolescent PCOS for irregular menses or hirsutism or infertility just for pregnancy or pregnancy with PCOS just till she delivers. It is our responsibility as a treating clinician that once she is correctly diagnosed, as Dr. Cipriya said, not underdiagnosed, not overdiagnosed. If she is correctly diagnosed with PCOS, you have to take 2 or 3 minutes extra to counsel her about the possible long-term health risks which are associated with PCOS, and you have to tell her about the screening methods, how frequently she has to do, and what test she has to do. So the key takeaways from my presentations are that the risk factors for metabolic syndrome, they include central obesity, hypertension, atherogenic dyslipidemia, and insulin resistance. It affects 33% of women with PCOS, and it has been less well researched than other features such as infertility, anovulation, and hirsutism. Consequences of metabolic syndrome include cardiovascular disease, type 2 diabetes, cancer, sleep apnea, and psychological problems. Cardiometabolic risk screening involves obtaining data on her smoking history, measuring her weight, calculating her body mass index, waist circumference, blood pressure, lipid profile, and doing an OGTT. Management of metabolic syndrome should focus on the risk factors and individual components. Lifestyle modification is the only universally accepted intervention. Metformin can be considered in those women who have impaired glucose tolerance, although there is no established duration of treatment. The use of newer drugs such as inositol Liraglutide requires further validation, while the use of statins should be limited only to those women who are having dyslipidemia. Bariatric surgery can be considered as a last resort in appropriately selected women. And last but not least, prevention is better than cure. So catch them young in schools and in your OPD when they are coming to you for management of adolescent PCOS, infertility, and PCOS with pregnancy. So thank you, friends. Thank you so much for your patient hearing.
Dr. Supriya, hi, I'm here.
Yeah.
Can I, Dr. Lakshmi, I was
yes.
not there, but I heard your whole lecture. It was really wonderful and it was really crisp and to the point, and you covered all the aspects of the PCOS and metabolic syndrome. And really, you are absolutely right. We have to catch the young girls, basically. That is the target, should be the target population, young girls and pregnant women. Because if we can motivate the young girls for the regular exercise, that is the most important thing nowadays. Because see, all the young girls or young children, they are on the screen. They have even the parents, they have forgot to encourage their children to go for the physical activity. That is the most important thing. I remember when we were children, we used to go for and play outside. Nowadays, everything is over. Young girls, they are not allowed to go out. They don't want to go out. They want only screen. They are playing on the screen. That is the main important thing. Because these are the future mothers. Once they are not doing the activity during their adolescent age, how can we expect them they will be active during the pregnancy? So that is the main issue. I think that is our target thing and important point to encourage the young women, young population, even boys, girls, they both all, everybody should be physically active. That is the important thing. But it was really wonderful. You covered all the aspects nicely. Thank you very much, Dr. Lakshmi.
Yes, Dr. Narayan, you want to say something?
Yes, madam, it is an excellent program. But what I suggest, do you like to give us a proposal regarding early intervention or prevention of PCOS, like lifestyle modification, school-based approach, so that we can roll out all the chapters, that each chapter should do at least 2 schools, 2 programs for 2 schools. That means we have around 32 chapters. So we can approach at least 60 schools.
Great.
That could be a small effort to enhance our social activities. And school approach will not be a big problem for any of our doctors or any of our chapter. You like to give us a proposal to the central office so that we can take up that issue.
We will give you, certainly. Dr. Yusuf, I'm so happy to see you. You stayed till last. And
indeed, it was a pleasure to listen to your talk. I think you coincided and completed everything very well.
It took me a lot of, I prepared from scratch that talk because I was also not knowing, there was not much literature and things on the metabolic syndrome in PCOS, but I thought we should educate and we should
it's beautifully
about this aspect. But yours was because most of the patients come to us for infertility and adolescent.
But Dr. Lakshmi, this metabolic syndrome in the adulthood is also very important because that is really important, because if we target these people and if we give them the importance of the lifestyle modification, that will be the wonderful thing.
Dr. Chandra, I'm so happy here there was one question about lean PCOS. Now you can answer that. Because nowadays we are seeing more and more lean PCOS also. So there was one question in the chat box. So what to do with them, lean PCOS?
Lean PCOS, I think they need medical treatment. Though they are doing activity, I don't know whether they are doing activity, but they should be motivated for the lifestyle modification. With their activities, physical activities, not to lose the weight, but to reduce the hyperinsulinemia. That is the most important thing.
Correct. That is what I wanted to tell the audience, because just because she is lean PCOS does not mean that she don't have to follow the lifestyle modification. She also has to eat right, and she also has to do exercise to reduce the insulin resistance.
Absolutely.
And then
Yeah.
only there is need for other medical management if she is having irregular cycles and all that can be covered medically.
One other, I think, just want to add one thing, Dr. Lakshmi. We need to remember that once this PCO patient, love, it's not the lifetime modification of her only, it's the lifestyle modification for whole family.
Correct.
You just can't expect the person next to you eating McDonald's and KFC, and she's gonna been given some kind of I don't know, green vegetables or whatever she likes, and that is not fair on that part. So the whole family has to make sure there is
You are
no fizzy drinks
absolutely
in the
right.
drink.
Yeah, you are absolutely right. Yeah,
That is why
the whole family should be motivated.
That is why
Yes,
we
the whole family.
obstetrician can do this work, because whole family comes to us when they are bringing their adolescent daughter, or when she's coming to us for infertility, when she's pregnant. We get the opportunity to counsel the whole family. But problem is that we are so busy obstetricians that we just can't take out 2 or 3 minutes extra to, counsel them. That is what I am requesting everyone. Just counsel them about the late sequelae of PCOS. And we never tell them that she should do the OGTT, that she should check her BMI, she should check her blood pressure, she should check her lipid profile. So once she gets a child, she also forgets that she was having PCOS, and family, of course, don't remember. So we have to educate them how frequently she should go and do all these blood tests, and she has to be very careful about her BMI. Especially perimenopausal. We are prone to gain weight during that period, perimenopausal.
And
Yes,
one thing which we, Dr. Lakshmi, experienced, that the patient, she comes to me before marriage, I was perfectly fine, my periods were fine. The day I got married, after that, everything was kind of haywire.
India also, we get similar kind of patients.
Because of all those laddus and mithais and everything, and then, the honeymoon period, and then they fall into that category, and then all the vicious circles, it all starts.
And once we put a probe, but we also get along with them, and we don't talk about the previous things. We say yes. We move forward.
Yeah. So it was wonderful, all the talks, and the program was well in time, madam, today. The 6:30 is about to go, and wonderful discussions. And thank you, Dr. Chandra, for joining in spite of your busy engagement today. And Dr. Yusuf, we had several webinars with the CEPOG when Dr. Rohana was there. So I had interaction with you for the menstrual hygiene speech I had given that day. So wonderful to have you always. And because of Dr. Lakshmi, madam, every time we had a very wonderful international speaker. And thank you, Narayan sir, for joining for the first webinar of your tenure. And we promise to keep on doing the good work and connect, and the school programs. We are passionate about that, and we'll be doing that also very often. So thank you everyone for joining, and I really thank the audience who must be listening, and I hope they benefited from our talk. I thank the Shield Connect People Society for doing all the groundwork and the platform. So thank you so much. Thank you, everyone.
Thank you. Thank you so much.